Everyone talks about the upside of value based care, the bonuses, the shared savings, but nobody talks about the phantom penalties that can wipe out your hard work. Even high performing practices, they lose money due to factors outside their clinical control. So today we are here to break down the top 3 dark sides or hidden truths that are likely affecting your bottom line right now in value based care. Hidden truth number 1 on value based care: measure complexity. Measure complexity is a trap. It's not just that the math is hard, it's that the way quality measures are structured often misaligned with true care quality. And let me show you what I mean by that. Let's discuss the first point regarding measure complexity. Why measure complexity? It is a trap in value based care. So I was in a quality meeting with one of the pairs discussing the practice's quality score and care gap status when I came across something that genuinely confused me. For the same quality measure, colorectal cancer screening, the pair's incentive program had 2 separate incentive buckets. So they divided this measure, colorectal cancer screening, into 2 measures, which is colorectal cancer screening, col E, which apparently can be done using any method, colonoscopy, CT colonography, FIT, DNA, FOBT. And then they had another measure which is apparently same. You see, colorectal cancer screening, colonoscopy only, right? And this is when it gets really deep. So I saw that on the care gap list, there is a patient who has to be screened or who is appearing for both these measures, right? So there's some patient, say Johnson, and he needs to be addressed for both of these measures. Now it is a bit confusing that how the incentive is going to be structured if a patient it appears for both the measures. So I asked a simple question to the pair that if a patient appears on the care gap list for both measures, which one actually pays incentive? And the pair, they told me that if you close the gap through colonoscopy only, right, then the practice gets incentive credit for both measures because you can do colorectal cancer screening by either of these 4 methods or you can do colonoscopy only. But the way that you get incentivized or a practice gets incentivized is that if they do colonoscopy, then they automatically get incentive for this one as well, right? And this made me pause because this is where the value-based care it gets complicated. If the goal is truly patient outcomes, then why should a practice feel nudged towards colonoscopy because it pays more? And what if a patient is older or frail, they have comorbidities, or maybe colonoscopy it carries real risk for the patient because of their condition? Or it can be that patient simply prefers less invasive screening, right? Every patient situation is different and shared decision making matters. But the design of some incentive programs, it subtly pushes practices towards the option that maximizes payment, not necessarily the option that is best for the patient, right? So I have to get this out of the way. This is true. The measures can get really complex, and sometimes the providers are not able to keep track of how they are incentivized on certain measures. So as a result of this measure complexity, no one in the practice knew that this is how they were incentivized on this measure called colorectal cancer screening. So providers, they often get penalized despite quality improvement because the measures are designed in a really complex, and I'm sorry to say, in a sneaky way. And it's a game where the rules are a little bit rigged, okay? But you have to put patients first, do the moral thing. I mean, you cannot push a patient to go for colonoscopy against their will, right? The second dark side, or the hidden truth about value based care, which many practices do not know, is that the care gap data is messy. It is not clean. And this is the most frustrating one. In most practices, the care gaps are already closed, but the pair data says you didn't do anything. Your practice didn't play any role in quality improvement. So the question is why your practice lagged? Because the pair care gap data is asking you to screen inactive members, deceased members, unavailable members with invalid contacts, members who already got screened. And that is the reason why auditing pair data is crucial. By the way, I linked the video on the top on care gap data audit. If your practice is struggling due to pairs messy data, check that out on how I help practices to audit their data. So what you need to do is to have a strict monthly data scrubbing workflow where your team validates pair lists against your EMR before the end of the quarter. Third hidden secret or a dark truth about value-based care is the sudden panel changes. And panel changes are good. I mean, obviously, if you are closing care gaps, you are getting assigned more patients, and that is a good thing for you, right? But imagine what if you are getting assigned all those new patients towards the end of the quality incentive program here. So the quality incentive programs usually last, from February to February. So it's based on a measurement here. And let's say that the quality incentive program, it is about to end, and you are about to either get rewarded or not rewarded on how you have performed throughout the year. But then suddenly, the pair assigns a lot of new patients to you under certain set of measures, and you're like, wow, so your quality score goes down. It can play against you as well. Be very careful. I will show you an example of this actually happening in a practice and how you can keep track of those changes. Be on alert. So, by the way, if you don't know how closing care gaps can change your panel size, it can get you more patients, I have linked that video on the top. The idea is that as you close more care gaps, it will increase your patient panel. But the very same thing can play against you as well, right? And let me show you how. This is a practice. They have not done anything about depression screening. They are not doing this screening. They are not doing supplemental, whatever. Right? And at this point, they have not earned a lot of incentive from this measure. Look at the denominator. They have 287 members. But here is the kicker. As they started to show some performance on this measure, yeah, we know, obviously, they showed some performance, so their incentive increased. But the total members have also increased. And this is a trap. What if you are getting assigned these members? What if the denominator is increasing towards the end of the program here? Let's say the quality incentive program, it's lasting from February to February or from March to March, right? And you are suddenly getting assigned these new depression screening members, or it can be members in any other measure. And you are getting assigned these new members suddenly in January or in February. And the quality incentive program, it ends in March. That is a kind of a predicament for you because your quality score goes down, right? So that can be a trap as well. Be on lookout for such trap cases. Let us wrap this up and recap the top hidden truths on value-based care. Complex measures, messy data, panel surges. They are designed to save the payer money, not your practice. But now, since you know it, so you can fight back. Regarding the complex measures, you should be curious about measure complexity and ask the pair why and how the measures are incentivized. Okay? This will hold them accountable on their incentive measures. Audit your care gap data. I cannot stress this enough. Be on lookout for the sudden panel changes, right? You will know that something is wrong with your panel if your quality score it suddenly goes down towards the end of the program here. All right? So, if your practice is interested in actually closing care gaps and getting incentives, I have broken that down into a 4-part series on how to close care gaps and maximize your incentives. Tap the title on your screen or linked on the top of this video. Let's move your practice from volume to value.